Hello and welcome. My name is Dr. Jack West. I'm a medical oncologist in Seattle, Washington, and I'm also the founder and CEO of GRACE, the global resource for advancing cancer education. I'd like to welcome everyone to today's program on lung cancer highlights from ASCO 2012. And this is a program that GRACE is doing in partnership with the Longevity Foundation. I'm very happy that we have two great guests joining us today, Dr. Mark Socinski, who is a professor of medicine and thoracic surgery at the University of Pittsburgh in Pittsburgh, Pennsylvania, and Dr. Joel Neal, who is an assistant professor at Stanford University in Palo Alto, California. With that, I'd like to turn it over to Dr. Mark Socinski to speak first.
Thank you, Jack. As always, ASCO brings us a number of new data sets that are always influential in how we approach our lung cancer population. I'd like to start with maintenance therapy in the PARAMOUNT trial, which was a late-breaking abstract at ASCO this year. Just some general comments about maintenance therapy, which is a relatively new paradigm in advanced stage 4 disease. Obviously, we have two approved agents in the United States. Both of them are approved as switch maintenance, meaning that these were not components of the initial so-called induction or first-line therapy, pemetrexed, based upon the results of a trial by the name of JMEN, and erlotinib as the switch maintenance option based upon the results from Saturn. The practice of continuation maintenance, or continuing an agent that was part of the first-line induction regimen, has been commonly practiced with bevacizumab. Most of our practicing oncologists do kind of use bevacizumab till disease progression, but continuation maintenance has not been commonly practiced with cytotoxic agents. In my opinion, maintenance is certainly an option for patients, but not a mandate. And treatment breaks remain an option, and I think some time off therapy when you're treating stage 4 disease, which again is a treatable disease in good performance status patients, but not a curable disease, I think treatment breaks can often be therapeutic for patients. The next slide shows the design of the so-called PARAMOUNT trial. This, again, as I mentioned, a late-breaking abstract, was a randomized, placebo-controlled, double-blind phase 3 trial. It used standard doses of cisplatin and pemetrexed in the initial induction therapy for 4 cycles. Standard supportive care measures were used. The primary endpoint was progression-free survival. So patients received, and again, this is patients with performance status 0 to 1 advanced stage disease, 4 cycles of pemetrexed and cisplatin, and assuming that you either had a response or stable disease per RECIST, there was an imbalanced randomization, 2 patients to pemetrexed and 1 patient to placebo. The trial was stratified for performance status, stage of disease, and response to induction therapy in this population of patients. Now, at ASCO 2011, we saw the curve on the left, which was the primary efficacy endpoint of progression-free survival. It was clinically and I think statistically positive and was a positive trial. That PFS was reassessed at the time of the final overall survival analysis, and there's relatively little change in the PFS data, and that was new data at ASCO this year. From the PFS, this is a forest plot, and you see that most, in fact all of the diamonds, deviate to the left, favoring continuation maintenance with pemetrexed. You can look at stage, a response to induction therapy, smoking status, sex, age, histologic diagnosis, large cell versus adenocarcinoma, and they all favor maintenance versus placebo in this analysis. The new data from ASCO this year was the impact on overall survival. This curve shows the overall survival from randomization. You see on the placebo arm 11-month median survival compared to 13.9 months for median survival on the pemetrexed arm. The unadjusted hazard ratio was 0.78, and I think that's a very robust hazard ratio in terms of what we do therapeutically in this population of patients. And you can see the slide lists the difference in 1 and 2 year survival, which is slightly over 10% in favor of continuation maintenance pemetrexed in those patients receiving first-line pemetrexed. If you look at the final overall survival from induction, you see nearly 17 months median overall survival with pemetrexed in this particular trial. There had been some previous data suggesting that the real benefit of maintenance pemetrexed was in those patients who had stable disease, and at least pemetrexed as a switch maintenance agent, the data was not as strong for patients who had robust responses to first-line chemotherapy that did not contain pemetrexed. You see here in this particular trial, looking at continuation maintenance, that both patients with responding disease as well as stable disease had very similar impacts on overall survival as a result of continuation maintenance pemetrexed. The PARAMOUNT post-discontinuation therapy was not influenced by whether you received pemetrexed or placebo. You see the top line, patients receiving post-discontinuation therapy, 64% for pemetrexed and 72% for placebo. You can see that the types of agents that were received were actually very similar, except for slightly fewer patients on the pemetrexed arm receiving docetaxel compared to the placebo arm. So my thoughts and conclusions about PARAMOUNT and how we should put this in perspective: it's a well-designed and well-conducted trial. It certainly supports the prolonged use of a cytotoxic agent after 4 cycles of first-line therapy, and whether we call this maintenance or prolonged duration, I think is a matter of semantic. This trial did show an improvement in overall progression-free survival, as well as overall survival with acceptable toxicity. I didn't show you that data, but we all think that of all the agents we use to treat this disease, pemetrexed does have a favorable toxicity profile. I think it's important to realize that the maintenance or continuation maintenance pemetrexed did not alter the likelihood of receiving subsequent therapies, and I think this trial does justify prolonged use of a cytotoxic agent as a maintenance strategy in this particular disease setting, and certainly shown to improve both progression-free as well as overall survival.
Thanks for listening. If you like and learn from our GRACEcast, you can subscribe on iTunes by just searching for the term Cancer Grace, find podcasts in the subject you want, pick a format of audio or video, and then just click subscribe. It's that easy. And for those of you who don't want to miss any of our programs, there's even a feed for all subjects. You can also find us on YouTube at Grace for Cancer Info, and that's the number 4 in one word, Grace for Cancer Info. Finally, if you haven't been there yet, please check out our Grace website at www.cancergrace.org. And don't forget that donate button in the upper right. Our content, which helps tens of thousands of cancer patients around the world every month, is made possible by your support. Thanks again.